Here we go. Hello, everyone. I'm Jackie Gruen. I'm the president of the HIV Oncology and Hospice and Palliative Care Network within the World Congress for Physical Therapy, and I want to warmly welcome Darren Brown. He's from London. He's going to tell you a little bit about his hospital, and be prepared to be blown away with what he's been working on in terms of developing guidelines and care for patients with HIV/AIDS. For those people who are are online with us right now, if you have any questions, what you can do is if you scroll to the very top, a menu will drop down, and you can click on chat. And if you have any questions, you can just type something into the chat line. And I say, yeah, David Tetris is here from New Jersey in the USA. Welcome, David. So I'm going to turn the microphone over to Darren Brown. But if you do have questions during the presentation, type them out in the chat line, and then as Darren can address them, he will within the presentation. All right, so let me turn mine off, and we can take it away here. Darren, we can't hear you. Darren, we've lost your audio.
Can you hear me now?
Yes.
Okay, sorry about that. Hello there. So thank you for having me. As Jackie said, my name is Darren Brown. I'm a physiotherapist over at the Chelsea and Westminster Hospital in London, in the United Kingdom. And my presentation today is going to be an evaluation of our specialist HIV outpatient physiotherapy service. And as you can hopefully see by my slides here, there's some Twitter handles and a hashtag. I'm quite a Twitter addict. So if you'd like to follow me on Twitter, you can, or follow our trust, you can at Darren A. Brown or at Chelsea West Foundation Trust, FT. But also, I'd really encourage people to use the hashtag REHABHIV. This is a hashtag that we've been using internationally for a lot of conferences, but also to try and get people to have an opportunity to network about rehabilitation in the context of HIV. So what I'm going to be talking about today is, first of all, just going through some of the basic epidemiology in the United Kingdom and also the role of physiotherapy, giving you an overview of the service that we provide, and also an update on the 2-year service evaluations that we've conducted, not only on our one-to-one clinic that we provide, but also on our group rehabilitation intervention. And then I'll also be guiding you through our new app that has only recently been released. And then finally, I'll be talking about some of the future opportunities that we've got, not only with research and further evaluation, but also expansion and the utilisation of technology. So in the United Kingdom, we know that there are 103,500 people estimated to be living with HIV, and this is in 2014. But unfortunately, a quarter of this population, 18,000, are still estimated to be unaware of their HIV status. And actually, 42% of people are still being diagnosed late, with a CD4 count of less than 350. We know that a quarter of this population are actually aged over 50. So this is either the people that are acquiring HIV in older age, or in fact people are aging with HIV. And we know that this population is actually due to double within the next 5 years. Now, the major populations of people living with HIV are men that have sex with men and also the Black African community. And as this graph shows here from Public Health England, men that have sex with men are the most prevalent population of people living with HIV in the United Kingdom. Hopefully some of you might be aware of the UN/AIDS targets of 90-90-90, which is that 90% of people living with HIV should know their status, 90% of people living with HIV should be receiving antiretroviral therapy, and 90% of those people receiving antiretroviral therapy should have durable viral suppression. Now, in the United Kingdom, we have free healthcare at the point of access, including access to antiretroviral therapy. And the data from Public Health England released last year, with the data from 2014, showed that we are currently still not meeting that in the United Kingdom. And even with free access to antiretroviral therapy, we can see that this target is a very difficult target to reach. Now, the reason I mention all of that is because actually we know that when we're thinking about a biomedical model, often when people now achieve an viral load, good viral suppression, and a good CD4 count, That's not the end of the story. We know that HIV is a complex systemic disease that affects many different parts of the body. So, for example, can have musculoskeletal effects, have cardiometabolic disorders, respiratory complications, AIDS-defining or HIV-associated malignancies, neurological complications, mental health and cognition, but also emerging aging and also frailty-related issues. And so because of this, many of these areas already have a strong evidence base in rehabilitation. But does that exist within the context of HIV? So I want to take it back to bare basics. What is disability? Well, we know that the World Health Organization's definition of disability is that it's an umbrella term covering impairments, activity limitations, and participation restrictions. So ultimately, this is a social construct. So for example, my impairment being that I can't bend or move my knee, therefore my activity limitation is I can't walk, so therefore my participation restriction is I can't get to the place that is meaningful to me. When looking at the level of disability, in 2004, Rush et al. Identified the impairments, the activity limitations, and the participation restrictions experienced by people living with HIV in Canada. And there was a really high prevalence of self-reported disability, when 90% of people experienced an impairment in more than one body structure or function. 80% of people experienced a difficulty with an activity limitation. And 93% of people experienced a participation restriction. So then what is rehabilitation in the context of HIV? Well, we know that it could be any services or providers with the aim to reduce impairments, activity limitations, or social participation restrictions. And the Canadian Working Group in HIV and Rehabilitation have defined this as a dynamic process that enhances body structures or function, activity limitation, and social participation restrictions to improve the overall health and well-being of an individual. So what has rehabilitation really got to do with it? Well, we know that people are living longer, and they're aging with HIV or acquiring HIV in older age. And so consequently, people are susceptible to developing health conditions that can either arise from HIV, the long-term side effects of antiretroviral therapy, or in fact, aging. Now, as a result, multimorbidity is actually becoming increasingly more common, especially as people are aging with HIV. Now, this combination of aging, HIV, and associated multimorbidity can result in physical, cognitive, mental, or social health-related challenges. And this collectively can be conceptualized as disability. And we know that rehabilitation is recommended to support physical, mental, and social health challenges. There is this episodic disability framework, however, that was created by Dr. Kelly O'Brien from the University of Toronto that describes the unique dimensions of disability experienced by people living with HIV. And these dimensions should seem familiar, in that you have your impairments, you have your activity limitations, you have your social participation restrictions. But the unique dimension of disability that came out of this qualitative research from 2008 was the dimension of uncertainty, or worrying about the future. What she identified is that the level of disability experience is fluctuating or episodic over the lifespan, years, months, weeks, and even on a day-to-day perspective, where the level of disability that people experience can either be exacerbated or alleviated by different contextual factors. So, for example, factors that may be external to you, like stigma or social support, or internal strategies or contextual factors, like your ability to maintain control, your attitude and your belief, or in fact, your age may have a huge impact on the level of disability you experience. Now, off the back of this, Kelly and her team have created a measurement tool called the HIV Disability Questionnaire that is currently starting to being used around the world that uses the episodic disability framework and those unique dimensions of disability experienced by people living with HIV to measure the presence, the severity, and the episodic nature of disability. We also know that as people are aging with HIV, Professor Patty Solomon from McMaster University in Canada has identified that uncertainty, that unique dimension that came out of the episodic disability framework, is becoming a much greater problem, because as people are aging with HIV, they may have uncertainty around their sources of their future health challenges or who may care for them, whether or not people have got appropriate long-term housing. How does that transition into retirement occur? The episodic nature of HIV has actually been shown to be disabling in itself because of its fluctuating and episodic nature. Also, people may worry about healthcare providers' knowledge and skills, and also financial uncertainty. Now, many of these things may not necessarily be unique simply to people living with HIV and may be associated with aging, but we know that some of the research is saying that people living with HIV may be aging slightly earlier or acquiring age-related comorbidities 5 or 10 years earlier than HIV-negative counterparts. Now, because of that, frailty has become a very hot topic in the context of HIV. So we look at what frailty is defined as. We know that frailty comes with age, in which often you will develop a loss of muscle mass or sarcopenia. That sarcopenia has an impact on your resting metabolic rate, can reduce strength and power, and reduce VO2 max and cardiopulmonary function, which ultimately can have an impact on walking speed, disability and dependency, and reduction in activity levels. And often this is a deconditioning spiral. Now, if we were to operationalize a phenotype of frailty, you can define frailty or someone as being frail if you have 3 or more of these 5 criteria: a shrinking of weight loss, weakness, poor endurance, slowness, or low activity levels. Now, we know that disability, frailty, and comorbidity really do overlap, especially when thinking about people living with HIV and multimorbidity. There are studies that are also showing that people are actually presenting with exactly this definition of frailty in middle age, within their 40s, living with HIV. And that may be a reduction in gait speed, a loss of weight loss, a reduction in activity levels, or exhaustion. So because of this, targeted exercise programs to increase physical activity, improve speed and power have been proposed to be evaluated as interventions to improve health-related quality of life amongst people living with HIV, because there's been shown there is a relationship between physical function and quality of life. Now, there is so much evidence on the role of exercise in HIV. There are many Cochrane reviews. Many of them have included some of those Canadian researchers that I've already mentioned, physiotherapy colleagues from Canada. We know that exercise in HIV is safe and effective because it has no significant impact on CD4 count or viral load, but it does lead to an improvement in cardiopulmonary fitness, body composition, strength, depression symptoms, and quality of life. And think back to that definition of frailty. We're looking at things like exercise time and VO2 max. We're looking at muscle strength. These are all things that are potentially reversible when thinking about the definition of frailty by using exercise as an intervention. But exercise is not that easy to participate in. We've all been that person that's joined the gym and then maybe not gone, even after Christmas. So Rick Kelly's team over in Toronto have also looked at people's readiness to engage in exercise, especially when living with HIV and multimorbidity. What they've shown is that actually people's readiness to engage is fluctuating, a bit like the episodic disability framework, and actually is highly related to the episodic disability framework. But what also they found is that there are these 4 sub-factors that really do relate to people's ability to engage in exercise or readiness to engage. So, for example, people's social supports, their perceptions and their beliefs, their previous experience with exercise, but also accessibility, such as of the facility itself or even finances. And so strategies to facilitate readiness to exercise should consider this interplay of these factors to improve the health and well-being of people living with HIV and multimorbidity. There are rehabilitation recommendations for adults aging with HIV that were released in 2014 in BMJ Open. And these recommendations include that rehab professionals should be prepared to provide care, should provide interventions that are individualized to the sensitive needs and unique values of people living with HIV, should be multidisciplinary, should take into consideration the extrinsic factors such as stigma and ageism, but also the intrinsic factors such as spirituality and self-management skills to provide rehabilitation. Also, aerobic and resistive exercises proposed, as is cognitive rehabilitation. And in the absence of high-level research, you should be looking at the other guidelines that exist in those known common comorbidities. So we do have recommendations for rehabilitation interventions. So what are we doing here at the Chelsea and Westminster Hospital? So we are based in London, down in the borough of Kensington and Chelsea. We are the largest HIV unit in Europe, and we have recently expanded. Here at the hospital, we provide inpatient rehabilitation, both OT and physio, for our HIV inpatients. But I'm going to be talking to you today about our outpatient HIV physiotherapy service. We can receive referrals from any of the clinics that we have in the trust, which includes 56 Dean Street in central Soho, 10 Hammersmith Broadway down in Hammersmith and Fulham, Hounslow Sexual Health Services, also sexual health services across Hertfordshire, and also we are hopefully soon to be expanding out into Sutton, which is further down in London. Now, the outpatient physiotherapy service that we provide includes both one-to-one interventions in a HIV specialist clinic, but also a group rehabilitation intervention called the KOBLER rehabilitation class. Now, I'm going to provide you some information about the 2-year service evaluation that we've conducted on our clinic. What we did was we wanted to find out who was accessing the physiotherapy clinic, what interventions people were being provided with, but also what was the outcome of receiving specialist HIV physiotherapy. And we did this in 4 key ways. First of all, we did a retrospective audit looking at the demographics of people that were coming and also the interventions that they received. We used the World Health Organization International Classification of Diseases, ICD-10 online version, to identify what were the common comorbidities that people were living with. We also used the World Health Organization International Classification of Function, Disability and Health, ICF. Yet we used their checklist version 2.1a as a retrospective method of identifying what was the impairments, activity limitations and social participation restrictions that people were experiencing. And then finally, we used the Euroqual standardized measure of health outcome, the EQ5D5L, that looks at health status, but also a visual analog scale of how you feel your health is. We only used the health status, which looks at people's self-reported mobility, pain, ability to perform usual activities, anxiety and depression, and I forgot on the 5th one. It's on my next slide. So the demographics of people that came, there was 137 patients that were referred into this clinic, and on average they were aged 52, so they were an ageing population. 83% were male, 80% had been living with HIV or diagnosed for longer than 10 years, and 97% had virological suppression or an undetectable viral load. So on paper, these people have been living with HIV for a long time, aging with HIV, and have well-controlled HIV. They come from all over London and beyond. We are one of the only services in the country that provides both the inpatient and the outpatient services like we do, but also the clinics and the group rehab program. There are other services, so for example, St Thomas's Hospital and Mildmay also provide services in London. But our patients were coming from all over. Mostly they were coming from the 5 surrounding boroughs, but you can see that people are coming from far and wide, and they're coming for this specialist service. We haven't got the reasons as to why people are coming so far. It may be that they're not able to access rehabilitation services that they require in their local area. It may be that they want to come and see a specialist that understands living with HIV. Or maybe they have trust and value the fact that they're receiving services in a place that they receive their HIV care. These are all hypotheses and we're unclear on that, but there's something we would like to explore in the future. The population themselves, as per their demographics, 87% of people were physically inactive and not meeting UK recommended guidelines on regular physical activity. 71% of people were living alone, somewhat unsurprising for the usual population of people living in London, I feel. 64% of people were living locally, as I showed in that last slide, and 61% of people were unemployed. On average, people were living with 5 additional comorbidities on top of living with HIV. And 87% of people could be classified as complex comorbid. Complex comorbid is a definition where you have 2 or more additional chronic conditions in 2 or more different body systems. So, for example, living with HIV, COPD, and bone and health issues such as osteoporosis. You would be classified as complex comorbid. So moving on to the second phase where we were using the ICD-10. The most common comorbidities that people presented to the clinic was depression. 42% of people referred to physiotherapy were depressed. 25% had chronic lower back pain. 21% had peripheral neuropathy associated with antiretroviral therapy. 20% had bone and joint health problems. 18% had high blood pressure and 18% had high cholesterol. And all of these things have a very strong evidence base for the effectiveness of exercise. When we subgrouped these, diseases of the musculoskeletal system and connective tissue was the most common subgroup of conditions that people were living with. Somewhat unsurprising if we think of the traditional context of outpatient physiotherapy. But also, mental and behavioural disorders, endocrine, nutritional and metabolic disorders, and diseases of the nervous system came out as top. So when we looked at the checklist using the International Classification of Function, Disability and Health, we were able to identify what were the body function impairments, what were the body structure impairments, what were the activity limitations, the participation restrictions, and the environmental factors of people's self-reported disability. In summary, what we showed is that people are presenting with pain. They're presenting with difficulty with movement of joints, mobility issues, an inability to gain remunerative employment, and struggle to participating in community life. Now, what's really interesting is we're able to compare this data to that of Sub-Saharan Africa. And the results in Sub-Saharan Africa were pretty much exactly the same, except in Sub-Saharan Africa, people also, on top of the same things that we found, also had challenges with self-care or the ability to wash and dress. So when we were looking at change over time in people who were presenting to physiotherapy, what we were able to show is that people who presented to the HIV Specialist Physiotherapy Service had significantly higher self-reported issues across all 5 domains of the EQ5D compared to HIV outpatients in the United Kingdom, and also in compared to the UK general population. So as you can see, 80% of people referring to physiotherapy reported a problem with mobility. 56% of people reported issues with self-care. 81% reported issues performing usual activities. 90% reported pain and discomfort. And 82% reported anxiety and depression. Now, we're also able to compare this data to other populations. So, for example, elderly adults in Europe at risk of hospitalization or mortality. Our index value is able to compare then to these populations. Our index value for a population presenting to HIV specialist physiotherapy was 0.44, which was worse than patients at 12-month risk of hospitalization, and was nearly as bad as patients at 24-month risk of mortality. This potentially is indicating that patients who are being referred to physiotherapy present with the same risk indicators of being hospitalized, or in fact having adverse health outcomes as elderly adults. Could physiotherapy, therefore, have a huge impact on improving survivorship, health outcomes, and hospitalization? So when we looked at the interventions that people received, most people were referred into the KOBLER rehabilitation class after the initial assessment of coming to the clinic. So 37% were referred straight into our group rehab program. 23% had a combined approach, so they either received one-to-one intervention and were referred on to another service, or they received a few one-to-one interventions because there was so much pain they actually needed one-to-one physiotherapy before they were able to get into the class. And with the onward referrals, they could be referred on to community services such as falls rehabilitation. It may be they needed pulmonary rehab or cardiac rehab. It may be that they needed an occupational therapist or a physiotherapist to see them at home. And I've also referred to community speech and language therapists and other services as well. Only 19% required just one-to-one intervention and then being discharged. So as you can see, most people that are presenting are actually not just needing just one-to-one musculoskeletal physiotherapy. Unfortunately, 21% of people did not attend before treatment cessation. However, when we looked back at their data, we were able to show that over half of them were showing objective signs of improvement, whether that be visual analog scales of self-reported pain or objective signs such as joint range of movement. Overall, over half, 53% of patients accessed the KOBLER rehabilitation class at some point. When we were looking at the change over time, we've only got a small number of those patients that received just one-to-one physiotherapy. So these are patients that didn't have combined intervention and didn't go into the class, just received one-to-one. Of these small cohorts, what we were able to show is that following intervention where on average patients had 3 sessions, there was significant improvements in mobility, self-reported mobility, significant improvement in self-reported ability to perform usual activities, significant improvement in pain and discomfort, and significant improvement in anxiety and depression. And what we also showed is not only was there improved median scores across all domains, so that also includes self-care, the index values that we obtained significantly improved that actually took us outside of that risk of even 24-month risk of hospitalization. This was a significant improvement and potentially is indicating that physiotherapy may be able to keep people out of hospital. So I mentioned that over half of patients who came to the service accessed a group rehabilitation intervention called the KOBLER rehabilitation class. This is an evidence-based intervention that was set up over 4 years ago. And it's based on the evidence of the Cochrane reviews on exercise that I mentioned earlier, but also existing exercise services. So, for example, Sula Philippas's exercise program down in Melbourne in Australia, but also the program that was set up at St Thomas's Hospital in London. We have recently published the data that we have done on our 2-year service evaluation of this, which you can access with the reference here up at the top right-hand side. The KOBLER rehabilitation class is a twice-weekly supervised group exercise program that includes both cardiovascular exercise, progressive resistance training, neuromotor exercises, so that's balance, gait, coordination, but also flexibility training. So we do flexibility exercises before and after, but we finish with a guided relaxation with some nice, calm and relaxing music and head-to-toe guided relaxation. We also include, which is our unique element, a self-management program. This has been modelled on pre-existing effective interventions in other chronic conditions such as COPD, cardiac rehab, pain rehab, and falls prevention, where we combine exercise and education. And we know in all of those other 4 chronic conditions, when you combine exercise and education, it's clinically effective, it's cost effective, it reduces health service utilisation, and it improves health-related quality of life. So we've done the same thing in HIV. We've made this HIV specific. What we've done with our education is that on a Friday morning before we exercise for about half an hour, we have a group discussion about living with HIV as a long-term condition. And we have different experts come in and talk with us about their respective fields. So, for example, a dietitian will come in and talk about healthy diets. Our occupational therapist will discuss fatigue management. Our advanced nurse practitioners will discuss a one-stop shop, kind of living with HIV, any Q&As that people may have or uncertainties that they'd like to address. Our sleep physiologist does a session on sleep disturbances, and our psychologists do a number of sessions, including a body image workshop, confidence and self-management, and also a goal-setting session. We also have community services come in, such as Positively UK and also Living Well CIC, who are both charities that come in and talk about the services that they provide. Our smoking cessation team does a stop smoking session, and we also get other external services that provide community-based exercise programs. So, for example, our local leisure centres and also the YMCA, which has the Positive Health Programme, which is the world's oldest exercise intervention based down at the YMCA. Our health advisors do a session on relationships and intimacy, and then also our palliative care, our symptom control doctors do a session on pain management. And finally, our occupational therapist does a session on stress and relaxation. We've recently added in a new one on cognition and memory, which is a joint one with our psychologists and also our occupational therapist. Now, originally when we set the programme up, we were basing it on the intervention that were provided at St Thomas's Hospital, which was a 10-week intervention that would have measurements done at week 0 and at week 10. And these measurements include height, weight, body shape, resting heart rate, locomotor or functional capacity performance measure called the 6-minute walk test, strength of upper limb and lower limb, a health-related quality of life outcome measure called the functional assessment of HIV indices, the FAHI. We do a flexibility test, and we also do GAS goals, goal attainment scaling, individualised goals that the patient has set collaboratively with the therapist. So we aim to do this at week 0 and week 10. But the key thing we noted very early on in establishing this service is that because of people's episodic disability and inability to maybe attend, and a third of our patients also being dual diagnosed with cancer and potentially going through anti-cancer treatments such as chemotherapy, most patients weren't able to adhere to the programme as we maybe would have liked to from our service delivery perspective. This is not linear. This is fluctuating. This is episodic. And so because of that, we decided to open up the sessions after 10 weeks and allow people to drop in, return, or in fact restart without having to require a new referral to come back into rehabilitation, remove those barriers, and improve accessibility. These are the goals that most people set. They set this collaboratively with mostly myself when they come and visit me in clinic before they go into the class. The most common goal that people want to change or work on is their body image. Most people want to lose weight, or since starting antiretroviral therapy or changing medications or starting another medication because they've got another condition, feels that their body is just not quite as
We've lost you. No sound.
Oh, sorry, can you hear me again?
Sorry, you put in.
That's all right, thank you. I think I got to maybe the goals, so I'll carry on. So body image was the most common goal, followed by participation, then mobility, and also health and fitness. People wanted to feel that they were doing something for themselves, that they were being healthy, that they were addressing a lifestyle intervention that made them feel good. Now, when we looked at adherence, adherence is defined in this 10-week parameter where you have 20 sessions that are available to you to attend, as attending 8 or more sessions. 46% of people were adherent to the intervention. But what we knew is that there were a whole bunch of people that weren't adherent, but we looked at what happened to them afterwards. And 37% of those patients who were non-adherent either returned or restarted the program later on when there was drop-in available and greater accessibility to return or restart. Now, when we look at the outcomes of the intervention, first of all, there's the 6-minute walk test, locomotor performance. People significantly improved. 86 meters was the average, and this exceeds clinically important differences in people with COPD, heart failure, stroke survivors, and community-dwelling older adults. There was a significant improvement also in strength of all muscle groups, so triceps, biceps, lat dorsi, shoulder press, chest press, and also leg press. There was a significant improvement in total score of health-related quality of life, but also within certain subdomains. Significant improvement in physical well-being, emotional well-being, and a trend towards improvement in functional and global well-being. There was also a significant improvement in flexibility by on average 8 centimeters. But I think the most important thing of all is 64% of people achieved all of their goals. And on average, people were setting about 3 goals. So what we've talked about is a breadth of research so far that there is disability experienced by people living with HIV. There is a need for rehabilitation. Rehabilitation interventions are effective, and there are even recommendations that rehabilitation should be provided. But even though we know that the provision of rehabilitation in the context of HIV is highly equitable, it is yet still hugely undervalued internationally, where there are huge variations in access to services, whether that be standard services or in fact specialist services for people living with HIV. Because of this, it is so important that us as physiotherapists collaborate internationally and work together to make sure that the voice is heard, not only of us as physiotherapists, but also of people living with HIV, that physiotherapy works, and physiotherapy can have a huge impact on health-related quality of life, physical function, disability, and independence. Because at the moment there is this huge variability in access, here at the Chelsea and Westminster Hospital, we have developed an app that I'm going to show you a video of now. This app was developed from a rehabilitation framework of helping people gain the information they need to live a healthy lifestyle, to make their own intention goals, and make behavioural lifestyle changes. I'm going to show you the introductory video, and then I'll explain a little bit more about that now.
Welcome to BU+, an app for people living with HIV. Today, living with HIV means you can live a long life like anybody else. So taking care of your body, mind, and life are important parts of being healthy and living well. Taking your medications and blood results are important, but there is more to living with HIV. So it is important you have information that is reliable, easy to access, and specific to your needs to support you to live a healthy lifestyle, live well, and achieve your goals. BU+ has been developed by experts from the Chelsea and Westminster Hospital NHS Foundation Trust to provide you with reliable information about your body, mind, and life when living with HIV. Information is provided in a convenient and accessible way so you can access what you need when you want it, allowing you to focus on being healthy, living well, and achieving your goals. In our health section, you can find content specific to your body, mind, and life. In body, find out about your heart, lungs, sexual health, aging, pain, and much more. In mind, you can get tips on how to self-manage issues with low mood and depression, self-esteem, memory, and body image concerns. In life, you can find inspiration for your goals on exercise, diet, sex, drugs, sleep, and living with a disability, plus much more. If you want more information, click on the hyperlinks in the text to visit a reliable website chosen by our experts. No matter what page you read, we will help you navigate around BU Plus and signpost you to other sections that you may find useful and inspire you to set your own goals. BU Plus gives you the ability to set your own personalised goals. We know keeping on track with your goals can be difficult, so our weekly progress scale lets you record how you did each day, and we will also send you a daily reminder notification. When you achieve your weekly goal, you will receive a reward video from our body, mind and life coaches who will give you inspiration and maybe some new ideas. BU Plus lets you input information such as your CD4 and viral load, list your medications and keep a note of the health professionals you see. BU Plus appointments syncs with your calendar to set useful reminders, and you choose what is included to keep your diary confidential. For easy access, your main screen also links to information on new diagnosis, peer support, keeping up to date, and I need help. We value your feedback, and our feedback tab lets you tell us about your experience of using BU Plus. BU Plus is passcode protected with your own 4-digit code needed to enter the app. All information you input into BU Plus is stored on your device, so nobody has access to your information other than you. So have a look around BU Plus and find reliable, accessible, specific information you need to be inspired, be healthy, and be well. BU Plus.
So BU Plus was released just over a month ago, and it's now cross-platform, available on Apple and also on Google Android versions. We have not only our website, we are also on Facebook, we are on Twitter, and if you'd like to watch that video again, you can follow the Vimeo link and watch that video as much as you want. The app itself has been relatively successful to date. It's been downloaded over 90 times in 10 different countries. It's been developed specifically with a bit of a UK focus. So a lot of the information was using UK charities and UK information from the NHS. However, it's really applicable to anyone, anywhere. And we were very mindful of that when we were developing the app. We are currently working with City University in London, in which we're going to be undertaking an evaluation of the experience of using BU Plus, and we're just about to start that, hopefully. And we're basically going to be trying to find out what is the impact of using BU Plus on health, well-being, quality of life, and self-management skills and the ability to self-manage. So there are lots of opportunities that we have been faced with here in the UK and specifically within this service. The first is that evaluation that I mentioned, the BU Plus. We're really fortunate that the BU Plus was developed as a collaboration not only between Chelsea and Westminster Hospital and our health charity CW Plus, and also their technology partners Imagineer. But now that we are also collaborating with City University in London to evaluate the experience and impact of BU Plus, this really has been a true collaborative, where over 60 different experts provided content for BU Plus, and we've had input from people living with HIV from the very outset. But we also have some other collaborations that are very exciting. So, for example, we've been collaborating with the London School of Hygiene and Tropical Medicine, a PhD student called Mark Spreckley, who's also a physiotherapist who's undertaking his PhD in public health. And he's been conducting a needs analysis of the KOBLER rehabilitation class, and hopefully those results will be available to share and publish soon. It's a multi-stakeholder needs analysis identifying what was the need from people living with HIV accessing the service, people that are providing the service, people that are referring into the service, but also people that are commissioning the service. What is the need for the KOBLER rehabilitation class? My understanding is so far the results have been very supportive and gleaming, but there's lots of constructive feedback that we're hoping to use as part of our further service improvements and expansion. In the UK, HIV is not included as a standard part of allied health professional undergraduate teaching. So therefore, physiotherapists, occupational therapists, and speech and language therapists that graduate as allied health professionals may not have been taught anything about HIV at undergraduate level. Because of this, we are currently, the Rehabilitation and HIV Association, are working with Coventry University to do a scoping review of the UK undergraduate education provided. We're expecting to find that there is a huge disparity in the level that is provided. The aim of this is hopefully to start to provide a benchmark for what is the level of education needed for allied health professionals in the United Kingdom to address the future needs of people living with HIV with disability. We're also hoping to expand our service. The Trust itself is continuing to expand, in which that we are now a partnership with another hospital. We have also been partnering with other HIV services in other parts of London. Because of this, we need to ensure that there is equitability and access to rehabilitation. We are currently a small service and we're based only at the Chelsea and Westminster Hospital, but the Trust itself is expanding. So therefore we have a much larger population. Now over 9,000 people living with HIV can access this service. But we're only hitting the tip of the iceberg. So we need to look at how we can expand and make sure there is equitable access for all referrals for people living with HIV in the Trust that have disability and require rehabilitation. I also mentioned all of the measurement tools that we are using in the KOBLER rehab class. Now, we are hopefully going to be looking at how we can improve our service by having uniform measurement tools, not only from the clinic, but also through to the class, but also looking at whether there's opportunities for screening tools in the clinic to identify the need of rehabilitation interventions for people living with HIV. We're also using Kelly's HIV Disability Questionnaire, not only in the over 50s clinic that we provide here, which is a specialist clinic for people aging over 50 with HIV, but we've also got the HIV Disability Questionnaire being used in the Dean Street cohort study, which is a very large study at Dean Street, which is in central London, of all new people diagnosed with HIV. So what we're going to be hopefully be able to identify by next year is what is the level of disability, so the presence, severity and episodic nature of disability of people newly diagnosed with HIV and also people aging over 50 with HIV. Another opportunity, in fact I had a meeting yesterday, is we're going to be collaborating with King's College London, so for example with Richard Harding and also Matthew Maddox being another physiotherapist. Looking at doing a phase 1 trial, potentially looking at a feasibility trial with a National Institute of Health Research NIHR grant to look at the feasibility of moving into a phase 1 trial. This will hopefully support the service improvement and development and look at how we can move forward with researching this intervention. We're also hoping to use technology as part of that, so potentially looking at whether we can use technology such as iPads or tablets so that people can start to introduce the measurements onto a tablet and they can start to get biofeedback of how they're changing over time. Another thing that I forgot to mention with our measurements is one thing we have changed is we're nearly at about a year now of doing this. We've also started to include a measurement tool within the KOBLER rehabilitation class, which is the 5-time sit to stand at every single attendance. Because what we were finding is that because people are only having their measurements previously completed at week 0 and then planned at week 10, but only 46% of people were achieving that, we needed to have a measurement that was assessing people at every single attendance. And the 5-time sit to stand has so far been really successful. And my plan is that I'm going to be writing this up for an abstract submission for WCPT Congress next year. We have also been using WHO 2.0, which is the World Health Organization's ICF checklist questionnaire. So we're using the 12-item questionnaire to measure the level of disability that's self-reported by our inpatient population. This again, we've been recording this for nearly a year, and I'm planning to again calculate what the results are of this and submit this again as an abstract to WCPT Congress for next year. So, in conclusion, people living with HIV are aging and are living with multiple comorbidities, but also functional disabilities, especially when referred to physiotherapy. Physiotherapy is an important part of the continuum of care of people living with HIV and disability. However, huge variation in access exists. People who are presenting to physiotherapy are presenting with well-controlled HIV, but are also presenting with complex comorbidity and high prevalence of disability and functional challenges. And actually, physiotherapy interventions can improve function, mobility, pain, and quality of life. Lastly, our app, BU Plus, is available to download now, so please feel free to share this with anyone that you think may be interested, and also we would love your feedback. So thank you.
Thank you.
You cut out again. Darren, your voice is off.
Sorry, it keeps going to mute. I apologise about that. I'd be happy to take any questions.
There are a couple on the chat line.
Oh, are they? I can't see them.
Well, one is from Dave Ketris. He wanted to know the cost of the application.
Yes, so the cost of developing BU Plus was £18,000. It was funded by our health charity CW Plus, and it was funded through something called Imperial Innovations, which is a collaborative with a large organisation called Imperial Innovations that provide funding for new novel innovations that are developed mostly through the NHS. So the funding was specifically for the development of this, but wasn't for the onward sustainability. And this is why there is a very small fee to download BU Plus so that we can continue to be self-sustaining.
Okay, Dave actually wants to know what's the cost to buy the app for a user.
So the UK cost is 99p. So with the current plummeting value of the pound, I have no idea what that is against the euro or the dollar.
I think it might be around $2.99, but I don't have my financial tracker here. But it's very.
Why they are a little bit cheaper for you.
If people have any further questions, go ahead.
Thank you. Hello there, we can see somebody. Hello.
Hello.
Hello there.
Hello.
Hello.
Hello, welcome.
Thank you.
Do you have a question or a comment?
Yeah, I've already written my comments to Darren.
I can't see the comments, I'm sorry. I wondered if you'd be able to ask me.
Darren, if you slide up, if you scroll up to the top and click on chat, that line will come up and then you can see the comments.
Yeah, I can't see any of them.
Okay. Nagozika, we're not hearing you, but I can read your comment. First, you said, "I love this innovation. Thank you." And then Nagozika said, "Please remind me of the app name," and the app name is BU Plus. Correct me if I'm wrong, Darren.
Jackie, thank you very much. Do you want me to go back to the slides where people can see that?
Okay.
Yes, you go back to the slides so that we can. I've seen that. Thank you.
There you go. Thank you very much.
What we're planning to do after this presentation is I'm going to contact the World Congress and we're going to put these links up on our website for the IPT-HOPE section, and then I'm going to contact the APTA, the American Physical Therapy Association, and add these links. And I think if anyone else would like to get the links, they can contact Darren through his Twitter account. Darren, do you want me to type up your Twitter?
I will go to the end, which has my contact details.
Okay, so Darren's contact information is here. Are there any other comments or questions? Okay, while we're waiting for people to, oh, Stacy Lynn, one of the people, says she'd like the link. So the link is up there. Yeah, the link is there now.
Jackie, was there any other questions? Because I didn't actually, I still can't see the comments that were made, so I'm sorry about that. Was there any other questions that came through during the presentation that I could answer?
Will the slides then or a reference list be available? What we're going to do is we post this recording to the WCPT IPT-HOPE website, but Darren, I don't know how you want to handle the actual slides or the references.
Yeah, if anyone would like to contact me, I'd be more than happy to send you a PDF version of this so you can access that.
Okay, because I think Dave Tetrick would like it, and you know how to get a hold of him.
Well,
Hello.
hello.
Okay, can we get your email? Maybe we can ask for the slides.
Yes, you can have my email. It is, let me type it for you. Here we go.
Okay, thank you.
There we are.
Thank you so much.
That's okay.
Thank you for your attendance. You know, Darren, one question that, well, first I wanted to congratulate you on this, all this data, all this carrying through the process. It's so important for us to be able to share this with other people and develop this in our own countries. One question I have, and it's a little bit of a personal one, I am really addicted to my lifestyle exercise tracker. Will there be the opportunity for these people to have some type of a fitness tracker with the application? Because I'm actually motivated when I see I haven't done my, 10,000 steps per day, or I haven't climbed enough stairs. So do you care to comment on that?
Yeah, so this was something that we really thought about at the very early stages of development of BU+. Because obviously health technology has absolutely boomed. There are apps for absolutely anything and everything. And so one of the things that we were really conscious of is that we wanted to think wide and think how big and good can BU+. And then we started to trim away at some of those things that we thought were unnecessary. And many of the things that we thought were unnecessary weren't actually unique to the app, because there are other apps out there that are available to do those things. And so we decided that our focus was actually going to be on signposting and providing people with linkages to reliable resources that are specific to HIV, but also to other things, so for example, other apps that exist. And so within some of the information, you will find within the app that there's kind of like your top 10 tips or your Be Inspired at the bottom of every page. And some of those may be actually encouraging you to look for example, apps that may be able to track your activity. And obviously we're not endorsing apps, so we've not been able to link to specific ones. I know the ones that I use, but other people use different ones. And I think that because there are so many amazing apps out there that have such high functionality, it would be a bit short-sighted of us to think that we could compete with all of those things. So we thought, rather than trying to reinvent the wheel of what other people are doing, let's just say people look for the stuff that actually is out there. So the key thing that we were doing, oh, my computer's deciding to update, was focusing on what's unique about BU+. And what's unique about BU+ is that we're not just thinking about CD4 and viral load. We're thinking about living well with HIV. We're thinking about achieving the things that are meaningful to you, your own intention goals, by having the reliable, accessible information that is specific to HIV, so you can do what you think is right for you when you want to do it and when you need it. So that's why we didn't include those things. But you're completely right. Those kind of motivational activity tracker things are so useful for people, and especially the ones that also give you a social networking. So for example, I know I use one called Strava. I find that really useful because then I can see what other people are doing when they're running as well. So I agree, but that's the reason why we didn't include those things in BU+. Okay,
I appreciate that. There is a comment from Darren, from Raina Colombo from Troy, Michigan, William Beaumont Hospital. She's saying, Darren, congratulations, great program. Raina is a director of a rehabilitation oncology program at her hospital system. And I've seen some of her presentations from an administrative perspective on this, so I'm sure this is right in line with what she appreciates and loves to see. And she would like to, can you elaborate on the body structure limitations? She was late.
Oh, do you want me to go back to that then?
Oh, I shouldn't have said that, Rain.
Okay, you're allowed. Let me go back to this slide. I've got too many things up now. So the body, oops, sorry, apologies. The body function impairment. So I did the top 3 in this. So pain, mobility in joints, and emotional function were the most common body function impairments. The most common body structure impairment was movement of lower extremity, followed by movement of trunk, and then spinal cord and peripheral nerves. So when you think about kind of the most common comorbidities that people were living with being depression, lower back pain, and followed by peripheral neuropathy, it's somewhat unsurprising that these are the things that were coming out.
You know, not to perseverate on exercise, but one of the things that I'm concerned about with some of these applications that I use for exercise tracking is that some people overdo, and what I like about them having access to your application is that they can go to the websites where they get good information, but it sounds like they also have easy access to a professional, you know, physiotherapist or a exercise person or a physician who can say, yeah, you know, this much is good, but once you start doing this much, it may be harming your bones or your joints or, you know, your immunity or whatever.
I think the key thing about this is obviously with the service that we provide, so not only the clinic but also the KOBLER rehabilitation class, and then also now the new app. It's almost about the different hierarchies of need. You know, I see the people that are coming to see me as almost a smaller cohort of people, the tip of the iceberg, that are living with HIV and have the most amount of disability. And the reality is actually probably an awful lot of people are living well with HIV and don't experience disability and can get on with normal life and participate in the things that they want to participate in. But there is a proportion of people that have disability, and my concern is I think that sometimes those people slip through the nets in traditional rehabilitation models because they don't have the condition that may enable them to go to a particular rehab service. Or rehab services are unfortunately, some are being cut around many parts of the world, or there may not be accessibility to them in the first place. And so I think people are falling through the net, and I think that's where my passion is, that actually I think it's important that we identify the rehabilitation need of people living with HIV and the valuable role that physiotherapy can play in that, in supporting function, independence, and health-related quality of life. So when we're talking about the hierarchy of need, obviously those that are most needy of physiotherapy in our trust have access to that. But then also, people may not necessarily need to see a physiotherapist. They may just need to get the information at the time that they need it, and that's exactly where the app comes in. So that there are sections like, for example, the exercise section was written by myself as a physiotherapist, and so therefore it's got a physio mind behind it. But it encourages people to access a physio if they are having difficulty. Like if they've started exercising and they've got an injury, well then get physio first. So yeah, so hopefully that kind of meets the different needs of people at different stages of their life, and as I say, that hierarchy of need.
Yeah, Darren, in the last couple of minutes, could you talk about what some of the barriers that people experience in getting care in your country, in your city?
When you say care, do you mean accessing physio?
Yep.
Yeah, I would say the biggest barriers that people face from what I have evaluated is we did a retrospective audit looking at the reasons for non-attendance to the KOBLER rehabilitation class. Amongst those people were classified as non-adherent. And what we found, the most common thing was actually episodic disability. The most common reasons that people could not attend was because of physical health challenges, mental health challenges. The other issue was travel and location. So travel being either a financial expenditure that they couldn't afford, or the fact that it was too far away as a location. But also other commitments. So some people may have actually started to have got better and gone back to work, and we saw them in our data as non-adherent. Now that's a brilliant, fantastic outcome. We want to see people get back to work and not need physio anymore. But we weren't capturing that because they didn't come back, and we weren't recording it or identifying that in our measurements. So, you know, our measurements looked like they were bad in the sense that only 46% of people were adherent, which is why I want to restructure our survey so that we are actually capturing those positive things. One patient said to me, the reason I'm not coming to the class is because since coming I realised how important exercise would be for me, so I've bought a bike, so now I can just exercise at home. So, and in my data was non-adherent, but actually that's a fantastic outcome if only we knew it.
Are there any remaining questions? Does anyone have any questions or comments or anything they'd like to add to the chat line before we end the session?
Yes, I've already I sent my question.
Please do.
I'm having trouble seeing the question. Could you tell it over the audio? Could you speak it?
So aside this presentation, please can you share a physio assessing protocol with patients with HIV? I don't think there's a protocol, and I think the reason that I can say that is because actually, as I've presented today, people are presenting with multi-morbidity and complex comorbidity and functional disability. And so I think the key thing is that actually when assessing somebody living with HIV as a physiotherapist, the key thing is to bear in mind is that you're dealing with multi-morbidity and that you need to use all your transferable skills from all different pillars of practice. So one minute you may be doing musculoskeletal techniques, or in fact you then may move into cardiorespiratory, and then other times it may actually be using other techniques that may be slightly more higher level. So for example, mental health techniques. So for example, maybe using skills adapted from the techniques of cognitive behavioural therapy, motivational interviewing, etc., etc. So obviously, because people are multi-morbid, as are presenting to my service, often I see myself as a bit of a jack of all trades. So I think it's very difficult to say there's a protocol. But I think if there is a protocol, I would simply say you must be prepared to treat anything.
Thank you so much for that.
Thank you. Well,
all right,
thank you very much.
Yeah, thank you to all the attendees. This presentation will be online on our website at the IPT-HOPE. And if you have any further questions, you can contact Darren directly, and he will be sending out, I hope you send the slides to me, so if I get any questions, I can send the PDF to people too. So thank you for your kind attendance. This was a wonderful presentation, Darren, and we will be presenting you with the IPT-HOPE International Scholar Award for your presentation here today. There is a comment from Raina. Darren, have you published this program?
Yes. I will go back to the reference. Oops. If you can still see the slides, I'm presuming. I'm very pleased it was published only this month.
Yes.
Yes. There. Evaluation of a physiotherapy-led group rehabilitation intervention for adults living with HIV, referrals, adherence and outcomes. It was in AIDS Care, published this year.
Okay. So I want to thank you again, Darren. Is there another question? Well, like I said, if not, this will be on our website, and we can continue the conversation through our LinkedIn site, or now we're getting up a Twitter account, or we have a Twitter account that we can contact people with or through. Darren, any final comments?
No, just thank you very much for having me. Much appreciated.
Oh, we love you, Darren. This was really great, really innovative. All right, so without any further ado, I'm going to say good afternoon to everyone, and thank you again, Darren. This was an extraordinary bit of work and a presentation.
Thank you very much, and happy Thursday, everybody.
Darren, that was great. That was great. We will be in touch.
Thank you so much for having us.
Thank you for attending the session. Have a great day. We will send out the slides.
You too.
Bye-bye.
Bye.